Welcome to your mammography experience at VCU Breast Imaging. Today you will be, or may already have, observed a screening mammogram performed by one of our technologists. Now we will talk a bit more about mammography and breast imaging. We will go over why and how we screen, screening guidelines, how mammograms are taken, assessing image quality, how images are evaluated by the radiologists, and finally how a workup is done for suspicious findings using other imaging modalities. Why do we screen? Aside from skin cancer, the most common cancer in women is breast cancer. The annual incidence in the U.S. is about 220,000 cases per year in women and about 2,000 cases per year in men. In general, this is about 1 in 8 women during their lifetime. Risk increases with age, with the average age of diagnosis being 61 in females and 60 to 70 years old in males. There are many other risk factors, including genetic mutations in family history, prolonged estrogen exposure, breast density, various lifestyle factors such as obesity, sedentary lifestyle, alcohol use, and more. Early detection increases treatment options and decreases mortality. How do we screen? With self-breast exam, annual physician physical exam, and screening mammogram. There are many organizations that provide screening recommendations. For example, the United States Preventative Services Task Force, the American Cancer Society, and ACOG, among others. Their recommendations vary slightly with regard to frequency of screening, as well as different evidence supporting screening for different age groups. The general recommendation, and what we recommend to our patients here, is annual screening mammography starting at age 40 for asymptomatic women. Women who are at higher risk with a first-degree family member diagnosed with breast cancer before the age of 50 are recommended to get their first mammogram starting 10 years younger than the age at which their relative was diagnosed. For example, if a patient's mother was diagnosed at age 46, then the patient would be advised to get her first mammogram at age 36. Women at higher risk can also be screened using a breast MRI in addition to mammogram, particularly women with dense breast tissue. Mammography is a low-dose X-ray of the breast used to detect breast cancer in its early stages. It is a valuable imaging tool that isn't without limitations, but is still able to provide detailed information about the architecture of the breast and the presence of disease. It traditionally produces a 2D image, but newer tomosynthesis allows for 3D imaging of the breasts. In addition to screening mammogram for asymptomatic patients, there is diagnostic mammogram for symptomatic patients, or if there is a suspicious finding on a screening. This is a mammography machine where the breast is placed upon the platform. The technologist expertly positions the body or tissue, and the paddle is lowered down to the breast securely, and an X-ray is taken. The 3D mammogram is just 2 pictures taken 15 degrees apart. There are multiple different views that can be taken that require a change in the angle of the platform or paddle compressing the breast, or a single area being compressed further using a special paddle for diagnostic purposes to magnify an area of suspicious tissue. Here we see the medial-lateral oblique view. This is one of 2 standard views used in a screening mammogram. The left breast is on the right side of the screen, and the right breast should be almost a mirror image of the left breast. Here we see the craniocaudal, or CC view, which is a second standard view for screening mammograms. There are many other views, each with their own particular uses. In diagnostic mammogram, there are additional views that can be used, such as spot compression, spot magnification, ruled views, tangential views, and 90-degree medial-lateral, lateral-medial views. Using the CC and MLO views and possibly an additional 90-degree medial lateral view, the radiologist can triangulate the position of a mass or finding in the breast. On a mammogram, the areas of the breast are broken up into anterior, middle, and posterior thirds. There are also anatomic regions such as subareolar and the retroglandular fat just anterior of the pectoralis muscle. So here we see the retroglandular fat just anterior to the pectoralis muscle, the subareolar area, and then the anterior, middle, and posterior thirds moving back in the breast. So for example, this mass is located in the left breast at 9 o'clock at posterior depth. So this is posterior depth. The radiologist can further clarify the position of the finding by thinking of the breast as a clock face and estimating the hour to indicate just how lateral or medial the mass is. On physical exam and ultrasound, A description of the quadrant, for example, the upper outer or lower inner quadrant, and the clock face time, as well as measuring the distance in centimeters from the nipple, is used to localize a mass so that others will be able to locate it too. And here we actually see this little triangular marker, which the technologist placed because this is a palpable mass. So this is where the patient pointed out that they can feel the mass. And it seems to correlate with this very evident mass here. Once the images are obtained, the technologist checks them for artifact, motion, and to see if they imaged all of the breast tissue. They look to see if there was any motion artifact from either the patient or the equipment, which is represented by blurry lines. Deodorant is also a common cause of artifact, which we will see a picture of soon. The technologist checks that they imaged far back enough in the breast to the line of the pectoralis major muscle. And in the MLO view, they make sure the inferior portion of the pec muscle lines up with the nipple. They measure the PNL, or the posterior nipple line, making sure that they are roughly in length on both views. So here we see some deodorant artifact with these little specks here, little white specks. And the patient was asked to wipe it off, and then on the repeat mammogram, we no longer see that. So we're not missing any areas that are obscured by artifact. Here we see patient motion artifact represented by these blurry lines, the trabeculation lines that are blurred out because of either motion of the patient or motion of the equipment. And here we see the posterior nipple line being measured out from the nipple all the way back to the pectoralis major muscle here. And they are roughly equal in length, so 16 and 15.8. So this is acceptable as evidence that they got all of the breast tissue they needed for the picture. The radiologist then reviews the images and writes their reports using descriptors from the BI-RADS lexicon and assigning a final assessment category that then dictates what the next steps in management should be. BI-RADS stands for Breast Imaging Reporting and Data System, and it provides quality assurance for breast imaging by making sure that all providers are using the same language to describe their findings and creating well-defined categories to minimize confusion in documentation and reporting. They first comment on breast composition, which can range from almost entirely fatty to extremely dense. So here we see that the breasts are almost entirely fatty, so it's on the lower end of the spectrum. And we talk about density because it's important because it can obscure small masses and it lowers the sensitivity of mammography. So here there are scattered areas of fibroglandular density. And these breasts are heterogeneously dense, so small masses may be obscured in the fibroglandular tissue. And these breasts are extremely dense, which definitely lowers the sensitivity of mammography. So next, the radiologist describes any findings, such as masses, architectural distortion, asymmetry, calcifications, or associated findings. For masses, which are space-occupying three-dimensional lesions that are seen on two views, the shape, margins, and density are described. So the shape can be oval, round, or irregular. So irregular is usually reserved for shapes that are neither oval nor round. The oval shape is elliptical or egg-shaped, and it may include 2 or 3 undulations. Round shape is spherical, ball-shaped, circular, or globular in shape. And like I said, the irregular mass is when it is neither round nor oval in shape. Margins can be circumscribed, obscured, microlobulated, indistinct, or spiculated. The microlobulated, indistinct, and spiculated margins carry with them their suspicious feature, with spiculated being very suspicious. Circumscribed is when there is an abrupt transition between the lesion and the surrounding tissue. At least 75% of the margin should be well defined. A mass for which any portion of the margin is indistinct, microlobulated, or spiculated should be classified on the basis of the most suspicious component. So, for example, if you have a mostly circumscribed margin, but a portion of it is spiculated, then you would classify that more as spiculated rather than circumscribed. Obscured is when the margin is hidden, superimposed, or adjacent to normal tissue, making it difficult to discern where the lesion starts and ends. A portion of the margin may be circumscribed, but more than 25% of it is hidden. Microlobulated is when the margin has small undulations, and this implies a suspicious finding. Indistinct is when there is no clear demarcation of the entire margin or any portion of it. And historically, this was called ill-defined, but now is called indistinct. Spiculated is used to describe margins that appear as lines radiating out from the mass, and this carries with it significant suspicion. Density can be high, equal, low, or fat-containing. High density means the X-ray attenuation of the mass is greater than the expected attenuation of an equal volume of fibroglandular tissue. It also carries with it a higher suspicion for breast cancer. Equal density is when the X-ray attenuation is the same as expected. Cancer is less likely, but it's still possible. So here you can see that equal density mass there, which is equal to the surrounding fibroglandular tissue. Low density mass is for low attenuation, but not fat containing. Cancer is less likely, but it is still possible. So the arrow there is pointing to the low density mass. Fat-containing masses are radiolucent and include lesions such as oil cysts, lipoma, galactocele, and hamartoma. They are almost always benign. Architectural distortion appears as thin, straight lines or spiculations that radiate out from an area or mass, much like a sunburst. There can also be focal retraction and straightening out of the fat planes or parenchyma that looks like the tissue is being pulled in at a point. It can be benign if it's due to fibrosis or scarring from prior surgery, biopsy, or trauma to the breast. However, if there is no history of those, then architectural distortion is a suspicious finding. It can be found on its own, or it can be found in association with a mass, asymmetry, or calcifications, which then increases the suspicion for malignancy. Tissue diagnosis is appropriate. So here we see the lines and the pulling in with the sunburst appearance around this area that is suspicious. Another finding is asymmetry. This is a unilateral deposit or area of fibroglandular tissue that isn't quite a mass. Typically, masses have convex borders, while asymmetries have more concave borders with fat interspersed. When seen on only one view, it is just called an asymmetry and is likely just normal tissue superimposed. When seen on two views, it is either a focal, global, or developing asymmetry. Focal asymmetries have to be looked at further to make sure it is not a mass, and global asymmetries can be benign and normal or can indicate possible malignancy when there are associated symptoms or features. Developing asymmetries are new, larger, or more prominent than on prior mammograms, and this raises some suspicion. Here we see an asymmetry in the left breast shown by the arrow. This arrow here, this asymmetry here. It is present only on the CC view and not on the MLO. The panels below show that the asymmetry is stable over time on subsequent mammograms. The focal asymmetry noted here in the left breast is shown by the white arrow. It is present on both views, thus raising suspicion for a mass. Here there is a larger global asymmetry when comparing the two breasts, and it is visible on both CC and MLO views. And here we have a developing asymmetry. So panels A and B show the right breast on two views. So this is a CC and an MLO of the right breast. And then 4 years later, panels C and D show the same breast, the MLO and the CC. An asymmetry has developed, as indicated by the dotted box, and it is present on both views. Since this is a change from prior, the radiologist would definitely be working this up further. Another common finding are calcifications. They are described by morphology and distribution. Morphology that is typically benign is skin, vascular, coarse or popcorn-like, large rod-like, round, rim calcification, dystrophic, fat necrosis, milk of calcium, and suture calcifications. Suspicious morphology is amorphous, coarse heterogeneous, fine pleomorphic, or fine linear branching, which raises the highest suspicion. And the distribution is diffuse, regional, grouped, linear, or segmental, and we'll talk more about that later. So skin calcifications are lucent-centered, and they can be seen along the inframammary fold, parasternally, along the axilla and the areola, and they're very superficial and kind of almost, they're right there along the skin. Vascular calcifications obviously follow the vasculature. They are parallel tracks and are linear tubular calcifications. Coarse or popcorn-like calcifications are large, so greater than 2 to 3 millimeters in diameter, and they are seen only in an involuting fibroadenoma, which is visible here in the picture. Large rod-like calcifications are linear rods greater than or equal to 0.5 millimeters in diameter. They can have lucent centers if the calcium is in the wall of the duct. Most of them are intraductal, however, and they radiate toward the nipple. They are associated with duct ectasia, and secretory calcifications are usually seen in women older than 60 years old. Round calcifications can be considered benign when they're diffuse and small, so less than a millimeter, and they may form in the acini of lobules. When they are smaller than 0.5 millimeters, the term punctate should be used. Rim calcifications, or traditionally or previously eggshell calcifications because they look like eggshells, are non-group calcifications that range in size from less than a millimeter to greater than 1 centimeter. They have a thin calcified wall. They are round or oval with smooth surfaces and a lucent center. The differential here is fat necrosis or the calcified wall of a cyst, which would both be benign. Dystrophic calcifications usually form in an irradiated breast following surgery and following trauma. They're usually greater than a millimeter in size, and they often have lucent centers and an irregular shape. Milk of calcium is sedimented calcifications in macro or microcysts. On the CC view, which we see here on the right, they appear round or smudgy, and they usually are, but not always grouped. Here on the true lateral, so lateral medial, medial lateral view, the calcifications appear semilunar, crescent-shaped, or curvilinear, so concave up, or linear. And this is defining the dependent portion of the cyst, so it changes with position and with the view. And because of that change, then you know it's a milk of calcium calcification. Suture calcifications are calcium that is deposited on the actual suture material left behind from prior procedures. Can be linear or tubular in appearance, and sometimes you can see the suture knots. So now we'll talk more about the suspicious morphology calcifications. Amorphous calcifications are hazy in appearance, and they're so small that you can't really give a more specific morphologic classification. If they are bilaterally diffuse, they can usually be dismissed as benign. However, the positive predictive value of malignancy for amorphous calcifications is approximately 20%. Therefore, calcifications of this morphology should be placed into the BI-RADS assessment category 4B. So we'll talk about BI-RADS assessment categories a little bit later, but 4B is reserved for more suspicious findings, and is also reserved for findings with a positive predictive value greater than 10% to less than or equal to 50% chance of malignancy. So coarse heterogeneous calcifications are irregular conspicuous calcifications greater than 0.5 to 1 millimeter. So they're smaller than dystrophic, but they still have that irregular shape. The differential here is breast cancer, but it's more frequently present in a fibroadenoma, an area of fibrosis, or trauma, indicating possible evolving dystrophic calcification. A single group of coarse heterogeneous calcifications has a positive predictive value of slightly less than 15%. Therefore, again, it would be placed into BI-RADS assessment category 4B of a 15% chance of malignancy. Fine pleomorphic calcifications have a higher positive predictive value for malignancy, 29%, than the amorphous or coarse heterogeneous, but still this would cause it to be placed in BI-RADS assessment category 4B. They vary in size and shape, and they're usually less than 0.5 millimeters in diameter. Fine linear and fine linear branching calcifications are thin linear or irregular calcifications which may be discontinuous. They're less than 0.5 millimeters in caliber, and the branching forms suggest filling of the lumen of a duct or ducts. Among the suspicious calcifications, fine linear and fine linear branching have the highest positive predictive value of 70%. So these calcifications should be placed in BI-RADS category 4C, which is a positive predictive value range of greater than 50% to less than 95% chance of malignancy, regardless of their distribution. So this has a bit higher level of suspicion and higher chance of malignancy. So for distribution, it can be diffuse, regional, grouped, linear, or segmental. And here they are listed in increasing likelihood of malignancy, with segmental being the highest chance of malignancy. Linear and segmental distributions are more suggestive of malignancy because that means the calcifications are likely in a duct or ducts, which could be indicative of evolving DCIS. So diffuse calcifications, they're distributed randomly throughout the breast. They're punctate and amorphous. In this distribution, they are almost always benign, especially if they are bilateral. However, DCIS can present as diffuse unilateral calcifications, so always keep that in mind. Regional calcifications are numerous calcifications that occupy a large portion of the breast tissue, so greater than 2 centimeters in the greatest dimension. They do not conform to a ductal distribution, and malignancy is less likely. So here we see the regional calcifications taking up a larger portion of the breast, demarcated by that red oval, and on the right it's magnified. Grouped calcifications occupy a small portion of the breast. The lower limit for grouped is 5 calcifications within 1 centimeter of each other, and the upper limit is a bit more calcifications within 2 centimeters of each other. And here you can see that they are kind of grouped in a smaller area there. Linear, they are arranged in a line, as the name implies, and they suggest deposits of calcifications in a duct. Segmental calcifications, the distribution suggests deposits in a duct or ducts and their branches. This raises suspicion of extensive or multifocal breast cancer in a lobe or segment of the breast. And there, between the two red lines, you can see that area or segment of the breast with the calcifications in more of a branching distribution coming out towards that area of density. So associated features can be found on mammogram, ultrasound, or physical exam, and when they are found in conjunction with suspicious findings such as a mass, this heightens the suspicion for malignancy. So these features are skin retraction, skin thickening greater than 2 millimeters, nipple retraction, trabecular thickening, axillary adenopathy, architectural distortion, and calcifications. Skin thickening may be focal or diffuse. Greater than 2 millimeters thickness is considered abnormal, and the skin is normally thick in the periareola and inframammary fold. So here we can see the left breast has significant extensive skin thickening. That is quite obvious here. Skin thickening can also be as a result of edema and things like congestive heart failure. It can be a consequence of that. Or it could also be seen in things like inflammatory breast cancer. Skin retraction is when the skin is pulled in abnormally. The differential for this is post-surgical changes. So the skin being pulled in from underlying scarring and fibrosis of the parenchyma and breast cancer. So here we see a mass with spiculations, and it's kind of pulling in this skin here, and you can see this little divot on the mammogram. Nipple retraction is when the nipple is pulled in or inverted. If it's a new finding, there is suspicion for underlying malignancy. If it is bilateral and chronic, it is not a sign of malignancy, and that's just the patient's normal. And here this BB on this mammogram is showing where the nipple is, and here you can see it is pulled in, and there's that divot there. Other findings are things like intramammary lymph nodes, which can look like a mass, and skin lesions such as warts that can be identified by a ring of lucent air around the lesion, and or skin markers placed by the technologist, as well as a solitary dilated duct, which we'll talk about in a second. So the intramammary lymph node, it's circled here and magnified here. It typically appears as a circumscribed oval or kidney-shaped non-calcified mass with an area of lucency that represents the fatty hilum. So here you'll see the cortex, and this area of lucency is the fatty hilum, and that's how you know that that's an intramammary lymph node. And here are some skin calcifications again, and like I talked about, they're kind of along the inframammary fold. They're very superficial. And these are the skin markers I talked about that the technologist place on the skin. If the patient has a mole or a superficial lesion or wart or something on the skin, then the technologist will place it on there so that the radiologist doesn't mistake this for any sort of mass or lesion inside the breast. Some skin lesions, you will be able to see a ring of lucent air around the lesion, indicating that it's more three-dimensional on top of the skin. So that's another way to tell if you don't have any markers on the skin. This is a solitary dilated duct, and the arrow is pointing to it there. This raises suspicion for malignancy, and it can be associated with non-calcified DCIS. So something to keep in mind. Ultrasound can be used in the workup of findings on mammogram and on physical exam to better characterize an area or lesion of suspicion. There is a separate but similar lexicon in BI-RADS for describing ultrasound findings. And ultrasound is not very good for visualizing calcifications like mammogram is, but it can provide information about cysts, masses, lymph nodes, and other things. As you can see here, ultrasound gives us valuable information about the composition of a lesion. The simple cyst on the left is fluid-filled. It is dark and anechoic with some posterior enhancement. The complex cystic mass has both fluid and solid components, and the solid mass shows some posterior shadowing. The intramammary lymph node can be seen well with ultrasound, as it can show the cortex surrounding the fatty hilum. So that's a way to differentiate a lymph node from another type of mass using ultrasound. Putting all of the findings together, the radiologist will assign the imaging studies a BI-RADS assessment category from 0 to 6. Higher number is an increased likelihood of cancer. BI-RADS 0 means that additional imaging is needed or prior films need to be obtained for comparison in order to definitively assign a final category. BI-RADS 1 is negative with nothing to comment on. BI-RADS 2 is benign, and the radiologist chose to comment on a benign finding. BI-RADS 3 is for probably benign findings, and initial short interval follow-up is recommended. BI-RADS 4 is for suspicious abnormalities with biopsy recommended. It is broken up into 4A, 4B, and 4C. 4A is low suspicion. greater than 2 to 10% chance of malignancy. 4B is moderate suspicion with greater than 10 to less than or equal to 50% chance of malignancy. 4C is high suspicion with greater than 50 to less than 95% chance of malignancy. So those were the categories I was talking about with regard to the suspicious calcifications before. BI-RADS 5 is highly suggestive of malignancy with a greater than 95% likelihood of malignancy, and biopsy is needed for tissue diagnosis. BI-RADS 5 is used when there is a combination of suspicious findings. When there is only one solitary suspicious finding, then category 4C is more often used. BI-RADS 6 is used when assessing a known biopsy-proven malignancy that has already been documented before. Radiologists use a standard method of reporting these findings, starting with describing the indication for the study, whether it's screening, follow-up, or diagnostic. Next, they describe breast composition. They talk about the density there. And then they talk about important findings, which we talked about previously. Comparison to previous studies is done. And finally, a final assessment category is assigned, followed by management recommendations and communication with the referring clinician. Diagnostic workup happens when there is a suspicious finding on screening or physical exam, and the area is investigated further by diagnostic mammogram, ultrasound and physical exam, and finally biopsy leading to tissue diagnosis. The goal in a diagnostic workup is that the patient will have every result with the exception of the biopsy results by the time they leave the appointment that day. Biopsy can be done with ultrasound guidance, stereotactic guidance using mammogram, or MRI guided. Ultrasound is used mainly to target suspicious masses or lymph nodes, while stereotactic biopsy might be used when targeting calcifications. Core samples are taken, usually about 3 to 4 samples, or sometimes more, and sent to pathology for a definitive tissue diagnosis. Fine needle aspiration samples can also be taken, but they only provide the pathologist with cells, and they are not a representative sample of tissue. Here at VCU, the turnaround time for biopsy results is only a day or two, and patients can be brought back to have their biopsy results given to them in person. Here is a prone stereotactic biopsy machine where the patient lies prone on the table and the breast tissue hangs below them. And here you see the paddle with this little cutout here, and it's through this cutout that the needle is advanced and placed into the breast tissue to get the sample. Here is an upright stereotactic biopsy system, which looks like the regular mammogram that we have, and this needle apparatus is attached, and the needle advances through this hole in the paddle. And in the stereotactic biopsy, which uses this mammogram to create X, Y, and Z coordinates that are then programmed into the machine to locate the area of concern, and then the samples are taken using vacuum assistance. So using the mammogram picture, the coordinates are obtained and then put back into the machine, so the machine knows exactly where to get the samples from. Once the samples are taken in stereotactic biopsy, the samples are X-rayed to ensure that the targeted calcifications ended up in the sample. So here we see these little calcifications in the tissue that was taken during the biopsy. Ultrasound-guided biopsy is done using the ultrasound machine and a handheld, manually operated device with a hollow needle that can be fired to take a sample through the mass. Typically, the imaging modality chosen will be the one that best delineates the target area based on its composition. So if you're targeting calcifications, typically you use the stereotactic. If you're targeting a different kind of mass, you'll use the ultrasound guided. So here on the left, we'll see the pre-fire image. You see the needle here that I'm pointing out, and this is the targeted mass. And on the right is the post-fire, where you can see that the needle has been advanced or fired through the mass, and that's how you know that you got the sample that you needed. And here at the bottom, you can see how the location of the mass is ridden, so it's left breast, at 130, 3 centimeters from the nipple, so pre-fire and post-fire. So this concludes the overview of breast imaging. We hope you learned more about this field and breast imaging's role in women's health. Thank you very much.